All right, we're going to continue with Unit 4, Impaired Urinary Elimination. Okay, here's a review of the anatomy and physiology. So how the kidneys filter is through a nephron that is here, and it goes through the little tubules here, and the blood is filtered in those. We call that this little mesh here of capillaries, the glomeruli or glomerulus, and that is what filters out the blood too. Okay, urinary diversions, please research these on your own, especially the ileal conduit. Know what it does, what its function does, and then big thing is this whole thing needs to be a sterile environment. This is not the bowels. Things are not contaminated. Urine is usually sterile coming out of the body. Diagnostics exams. The first one is going to be a KUB. A KUB is just simply an x-ray of kidneys, ureters, and bladder, visualizing where the kidneys are and the bladder. And then this is going to be your IVP, the intravenous parallelogram. This is dye that is inserted, and then either like a CT or an x-ray is taken, so you can see with the x-ray that there's a blockage here. Otherwise you would have streams on both sides. All right, another one, CT. It's a fast, detailed radiation, can release structures very quickly and stones and things like that. Ultrasound, no radiation. There is some limitation to what we can visualize here, but we can still see some stones or other different obstructions. Cystoscopy, this is where a tube is inserted through the urethra into the bladder in order to visualize the bladder. There is a camera on there. Special considerations, allergies to latex, allergies to dye or shellfish. Shellfish would mean they're going to be allergic to the contrast media. Radiation exposure should be taken into consideration, and then any special preps like emptying the bowels ahead of time needs to be notified. All right, let's look at obstructions. The first one is going to be calculi, specifically renal calculi. These are formed through urolithiasis, which is stones forming in the renal system. Stones or calculi can block or partially block kidneys, ureters, or the bladder. So diagnostic, or what causes this? There's different types of causes. It's usually going to be a calcium surplus, like somebody that has too much dairy consumption, people that eat too many Tums. My dad was a victim of that. He ate Tums like it was his job. He did not follow the instructions on the bottles. And well, he ended up with kidney stones because it just was calcium, and then pop can also cause them too. And then they can be made of other substances that might be in the diet as well. Assessment. So what are we going to find for assessment? Typically, they're going to have something that's called flank pain. This is that lower lateral pain on the back. So it's kind of towards the side, but kind of in the back. Those are where the kidneys set, and it is very common to have pain there. You can also have pelvic pain, and then blood and urination. Those are going to be your kind of blood in the urine is going to be your top symptoms. For diagnostics, we can do KUB in an IVP, CT, MRI, ultrasound can also be used to diagnose people with those. For treatments, we're going to have to provide pain relief. That is our priority as a nurse caring for somebody with a renal calculi. All the urine output will need to be strained for the stone. We're going to keep the stone and we're going to send it off to the lab to see what it's made out of, because maybe a person just needs to do some simple diet modifications in order to prevent stones from happening again. And then for larger stones, they may have to be like lithotripsied, meaning broken up through ultrasound waves. A person still has to pass those fragments, and they can be extremely painful. Stones, as they're going through the renal system, they're jagged, they're sharp, so they're cutting things along the way. That's why there's blood in the urine, and they can just be so big that they don't pass. And then sometimes they just have to go in and surgically remove the stone altogether. One of my friends, her husband just had a kidney stone the size of a watermelon seed removed from his kidney, so they can be quite large. So here's another picture the stone moving through. And then you guys, your ureters, these are like the size of the end of your pen or pencil. They're very small tubes. BPH, benign prostatic hypertrophy, or hypertrophy, however you want to say it. This only develops in men because only men have prostate glands. This grows in size due to hormonal fluctuations. Affects 90% of men. This typically begins around age 50. So what happens with this is that the prostate gland starts to obstruct the urethra, like you can see in this picture here. For assessment findings, we're going to have weak stream, difficulty starting, which we call hesitancy, dribbling, urinary retention, and nocturia. Consequences would be reflux or backflow of urine to the kidneys through the ureters. Treatments. The most common treatment that we have is going to be the TURP, which is a surgical procedure. This is a transurethral resection of the prostate, also nicknamed the Roto-Rooter. For nursing care with the TURP, it is continuous bladder irrigation. So they're going to have fluid constantly running in the catheter that is in their bladder. So fluid is constantly coming in and constantly going out. And right after surgery, we expect it to be red, then get a little bit lighter and lighter and lighter. If it goes from light back to dark red, then we know that there's an issue with hemorrhage or something. They can become occluded as well with blood clots, so it's very important to keep a good eye of what's going in and what's coming out. We always have 2 bags hanging when we're doing continuous bladder irrigation. That way when one bag runs out, the other's just going to take up. We don't want there to be a time where there's no water flowing. Then I got a couple of medications that can be used for treating BPH as well. Finasteride, this one is very, 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 very common. It shrinks the prostate and allows urine to flow. And terazosin is also another one and can help treat hypertension as well. Okay, prostate cancer. So we talked about the benign growth of the prostate. Here is now not benign. This is going to be cancer. This is abnormal growth of cells in the prostate. So rarely occurs before age 40. So it's common to see, depending on providers and which standards they want to follow, to start doing rectal digital exams to examine the prostate at age 40 is not unheard of, but by the age of 50, they need to start being done. They're going to be on males, particularly males with family history of disease. There may be an occupational exposure to certain chemicals. I think about, our war veterans, especially ones that were over in Vietnam. They're exposed to a chemical called Agent Orange that is known for creating cancer problems. Diets high in animal fat put them at higher risk. High testosterone levels, because these cancers are typically driven by hormones, either estrogen or testosterone. If detected early and confined to the prostate, there is almost a 100% 5-year survival rate for this. So if it's detected early enough, we can pretty well cure these people. So for assessment, we're going to hear the same things with BPH: dysuria, hesitancy, reduced urinary stream frequency, nocturia, hematuria. And then here's where it gets different is with a digital rectal exam, the prostate will be hard and enlarged. With BPH, it's typically still soft. With this is going to be hard. Musculoskeletal consequences: bone and joint pain, back pain, neurologic, can have lower extremity weaknesses, bowel and bladder dysfunction. Remember, weight loss with any cancer. So, because they just take up so much energy. Consequences can be asymptomatic in the beginning, but usually there's going to be symptoms pretty quick, and the patient needs to listen to their body and just get into the doctor and have it checked out. People can be very hesitant to go to the doctor with this because they're going to end up needing a digital rectal exam, which they're not thrilled about. But it is a quick, easy way that we can, see what's going on or feel what's going on. Typically, this will spread to the lungs and liver and to bone marrow, and we don't want it to metastasize those places, because if they do, then we're really looking at an uphill battle. Compression fractures to the spine can also be common with this. Diagnostics, like I talked about, the digital rectal exam. PSA is a blood test. There is a normal, and then if it goes over the normal, and that doesn't really tell us that, for sure that person has prostate cancer. That's the first thing that the person needs to know. It's just a screening for it. The other thing is, it doesn't matter how high that number goes. It doesn't go up in relation to severity. It's like, yep, we've got something going on, or no, we don't have anything going on. Other things that can raise the PSA is simply just like an infection in the prostate can actually raise the PSA significantly as well. Transrectal ultrasound can be done, tissue biopsy, and a bone scan. Treatments, hormone therapy, and orchidectomy. This is where we remove the testes or through medications to block that testosterone. Side effects, loss of libido, erectile dysfunction, impotence, hot flashes, gynecomastia, which is breast enlargement, and then body image issues. They might need prosthetic testes. Radiation may need to be done. Other surgical things would be a prostatectomy. They're simple and radical. With that, you can have urinary incontinence, erectile dysfunction, and hemorrhage or bleeding. Artificial sphincter may need to be placed in order for a person to have control over urinating. And then cryosurgery is freezing and thawing of the prostate tissue in order to get it to, stop growing out of control. Stricture. So a stricture is the narrowing of the urethra. I have a picture on the next slide here that you can kind of see in your picture. This diagnosis is not in your book, so don't go searching for it too hard. This can be in males or females where they have this stricture, this narrowing of the urethra. It can be inflammation, different procedures, scar tissue, or from STIs. Assessment, obviously they're going to have decreased urinary stream. They may have bladder distension because the urine is retaining inside the bladder. Feeling of an incomplete bladder emptying. May have a spraying stream. So with kiddos, this is where they're like, well, when they pee, it's really weird. It's like it's shooting out to one side or something like that. Like that's going to be, a huge concern. Frequency, urgency, UTI, retention, like I said. Consequences, urinary reflux, where the urine is going to travel back up into the kidneys and create a toxic environment for the kidneys. UTIs, bladder retention and distension, and sexual impotence. So this, they can't get rid of the urine. That's a toxic substance in the body. That's the waste. And so we need to do this. We need to treat this. So treating the underlying cause, if it's infection or stones, we're going to treat that. If it's we may need to do a urethral dilation where we just have to go in and stretch out those tissues again. A stent may need to be placed, or a reconstructive surgery may need to be done if it's looking like a more permanent thing. So here's a picture of the stricture here. Okay, testicular cancer. Testicular cancer, this is abnormal growth of cells in the testes. The at-risk population, check this out, 15 to 40 years old. 15 years old. There's a big movement right now to try to educate as many high school boys about doing their own self-testicular exam, because look at that age. This is your young population that's being affected. And the cure rate is 90%, which is good. Cryptorchidism, this is where you have a hidden testy. It hasn't dropped yet. Family history of testicular cancer puts a person at higher risk. Men living in the US, UK, Scandinavian are at higher risk. African and Asian men are at lower risk. Smoking increases the risk of everything, right? Exposure to endocrine disruptors, so different pesticides, cosmetics, and nail polish. Most men have no existing risk factors, which is why it is important for a testicular self-exam to start at 14 years old, and best to do it after a warm shower. Looking for a painless, hard nodule, usually going to be in one testicle, may have a dull ache in the pelvis or the scrotum, but typically not. It's just going to be this hard, painless nodule. Consequences, metastasis to other issues and into the blood. Metastasis to other tissues and into the blood. Treatments are going to be medications like chemotherapy, radiation, and surgery. They may do a radical orchiectomy. That will be primary treatment. They're going to try to preserve function to ejaculate, and a prosthetic might need to be placed if necessary. All right, I'm going to pause it here and we'll continue with the next one.